TopMedTalk.
Hello, I'm Desiree Chappell, and this is TopMedTalk. We are here in Orlando, Florida for Anesthesiology 2019, the annual meeting of the American Society of Anesthesiologists. With over 14,000 delegates, this is the largest gathering of anesthesiologists and anesthesia providers in the world. Now, as usual, I'm joined by my co-host, Professor Monty Mythen, our editor-in-chief of TopMedTalk. Hello, Monty.
Hi, Desiree. Great to be here as always.
You're here. You weren't
yeah,
here.
I made it. I made it back.
I know.
Exciting little sojourn, a little trip to London to pick something up.
Yeah, like the award for Carrie Man of the Year.
Carrie Person.
I'm sorry, I do say man. Carrie Person of the Year for the Carrie Association of London.
There we go.
So high honor for you.
A third ASA.
It is our third ASA. We are here in the trade exhibition. We're on booth 730. And we want to graciously thank our sponsors this year, Edwards Life Sciences. They are in booth 727 right across the way from us. So please stop by and say hello to them. Say hello to us. Hello. Thanks, everybody. We also want to say thank you to the ASA because they have been very gracious to us this year and very welcoming. And we really appreciate the engagement and the desire to share knowledge through TopMedTalk. So thank you, guys. So today we have lots of great interviews. Our first one is with a friend of the TopMedTalk family and a superstar, actually, of TopMedTalk, Professor Carol Peden from Keck Medicine, the University of Southern California. Carol, you are a superstar, whether you know it or not, on TopMedTalk. You are on our editor's pick list that we are putting out to all of our subscribers now. So top of the list, Carol.
That's fantastic. Thank you. And it's great to be here.
Yeah.
And it's great to be here with this wonderful team.
That's right. So, Carol, we were talking the other day and you said, I have to bring our enhanced recovery team from Keck because they are doing such amazing things. So why don't you introduce who you've brought here to the TopMedTalk pop-up studio in the ASA?
In no particular order, I have Robin Cresner, who's an RN, CCRN, and she's one of our quality improvement implementation experts. I have Dr. Shane Dickinson, who's an anesthesiologist, and I have Shoo, who is our project manager for the team and incredibly organized, and we have all these amazing resources that she pulls together.
Yeah, that's amazing. So I was over at your guys' booth, so congratulations, because I just saw that you won an award here at the ASA. Robin, what did you win?
We won second place for the exhibition.
Oh,
the scientific
exhibition,
yeah.
The scientific exhibition. So that's really, really cool. And one other thing I noticed in your booth was a big roll-up banner talking about something that happened in U.S. or was out in USA World News. Was it?
Yeah, we were just recently named the number 16 hospital in the U.S., which is obviously great, but also it's fairly unique because we only became an academic medical center 9 years ago. So it's quite a rapid rise up the rolls.
Well, very impressive. Congratulations to you guys. But what, as a fellow enhanced recovery implementer, struck me the most, what I saw at your booth, was all the materials and everything that you guys were putting together for your enhanced recovery program. So, Robin, actually, why don't you start out by telling me a little bit about your background and your role in this program and kind of where you guys are right now?
Okay, so I've been a registered nurse for about 25 years, mostly critical care, and about a year and a half ago, I started a role as a clinical improvement fellow in our value improvement office. And I was assigned to work with the ERAS team. Well, the ERAS team was being formed at the time, actually, to create a way that we can improve our service to our surgical patients. And we've rapidly grown from one service line all the way to 9 service lines. And so now almost 60% of our patients that are receiving surgery at Keck are being cared for with an enhanced recovery pathway.
That's fantastic. And how many service lines did you say you have?
9 service lines.
9 service lines. And those are, thoracic?
We have thoracic, CT surgery, urology, GYN, ENT, vascular, ortho tumor,
plastics. Something
Plastic.
That's a long
ENT with plastics.
And
yes.
Robin, is anyone resisting, or is it just a matter of getting round to the next team?
Well, that's a good question. I think initially there could have been more resistance. However, the first team that we chose to start with ERAS was our thoracic team, which the leader of their team was a very gung-ho and very ambitious about making ERAS work. I think he was very familiar with the ERAS program, and he really helped us publicize it, especially by the positive outcomes that his patients had. It got more physicians in our facility on board.
I think when I talk about QI implementation, I always talk about, get the early adopters and get some easy wins. And that's exactly what this thoracic surgeon did. He was enthusiastic, he was keen, he was easy to work with, and he showed success. And then all the other surgeons started looking and saying, this looks good. We want to do this too.
So it didn't matter the service line. It's whoever's the most engaged.
Well, again, in implementation principles, it's don't fight battles. If people aren't interested, don't go there initially because you don't have the resources. Find the winners, go for that, and then the others will come on board.
Yeah. Now, Carol, we've talked a lot on TopMedTalk about some of the things that you've been involved with in the UK. So the Enhanced Recovery Initiative back with Monty, years ago, as well as a couple of the studies that have come out with the EPOC and the ELC. Can you tell us just quickly a little bit about those again?
Well, EPOC was evidence-based perioperative care for high-risk surgical patients, and the Emergency Laparotomy Collaborative was focused on laparotomies. They're both trying to do the same thing for very, very high-risk patients, but EPOC was more like an enhanced recovery pathway in that it was 37 components, and ELC, we just focused on 6 key things. ELC was, and we also used the synergy of a collaborative with ELC, which I think we've seen with our work at Keck, in that bringing teams together, sharing ideas, making multidisciplinary, really accelerates progress. Whereas with EPOC, because it was done as a formal step-wedge randomized controlled trials, to a certain extent, teams couldn't mix so much. Having said that, we still saw success in that we improved 1/3 of processes across 95 hospitals in a relatively short time frame. But I think, for me, the learning is probably start with a few key things, and we were talking earlier with Robin, with our pathways, we've had some success, we've had some failures, and we've seen where we need to focus more. So I think find where you need to focus, where the biggest gaps are, or where you can have people that will work with you or easy adoption. Start there, share the learning, and then build on that.
You guys were saying that Carol's been a really great mentor for you in this program, but you said I've kind of stepped away a little bit, but I think it sounds like everything that you've taken away from these.
I've been very light touch. These guys have done a masterclass in implementation. They've really done it amazingly well, and I have to say the resources, once we showed results, the resources that the hospital has given us now.
I was going to say, so we're pointing to Snow over here. Yeah. So Snow, can you introduce yourself, please?
Oh, hey, my name is Snow Shusan. Chinese first name, can't pronounce. So I graduated from USC at Trojan from Industrial and Systems Engineering. Very different background than all of you all, being clinician. I've been working at the hospital value improvement office in the past, doing performance improvement work, as well as obviously data analyst. We can't do any improvement without data. Recently joined Anesthesia, joined the fantastic ERAS team, have been a project manager for the team, working closely with our clinicians, engaging all of our care providers as well as the patients.
That's great. So I saw you were showing me a little bit earlier some of the structural stuff, and we'll put, you can't see this on Twitter now, but we will definitely be putting this up whenever we repost this particular podcast. But this is all kind of developing the system, the teams and things like that, and that's kind of what your role has been.
Yes, so we have a fantastic team of clinical providers on top of their regular clinical jobs, spending time in OR, spending time on the floor. So my role is essentially help people kind of put things together, keep things organized. Let's keep our schedule on time. Let's meet with this group. Let's talk about this. This is overtime. Obviously, I also manage a budget for our project team. We have multiple events. We have multiple events going on all the time. As Robin mentioned, we are working with 9 different service lines. So every service line has different progress, and they have different levels of, we just need to keep everybody on pace.
Yeah.
But still, I'm just noticing your badge there, and I think Robin says the same. The power of interdisciplinary teams, is that right?
Yes.
I love that. So that's your strapline, is it? Or your title, or the power of the interdisciplinary team?
This is what our booth, this is the title of what we were presenting. Basically, how having this interdisciplinary team come together really makes things work. And this is how we've had success with our ERAS program, is by having an interprofessional team. We reach out to everyone who takes care of ERAS patients. We meet with surgeons, with physical therapists, with pharmacists, with nurses.
Everyone counts.
Yeah.
Everyone counts, and we ask for their feedback.
I would say that's been so impressive by this team, and I have to shout out for somebody called Mike Kim, who is an anesthesiologist and the total driving force behind this. He's on holiday in Korea at the moment, so he can be here, but we can't not mention him. But I think one of the things Mike particularly was really good at was going and talking to everybody, absolutely everybody that he could think of that would ever feature on the patient pathway, and bringing them into the room so that everybody felt they owned this pathway and the project.
Awesome.
And Shane, from team anesthesia perspective, one of the things we often, so I'm an anesthesiologist, we often get thrown at us is that we have control over many of the solutions, but we're often the biggest problem. How was it for you? Does that sound familiar at all?
It does sound familiar, and it's a nice segue into my role with the Enhanced Recovery Program. And I never wanted the anesthesia department to be a rate-limiting step in any of this process. And so with each service line, we identify appropriate individuals in our department that are familiar with the cases and formally train them not only in the operating room, but with lectures and seminars, and ensure that everyone's on the same page, everyone's comfortable with the protocol before we formally introduce it.
And if you had any pushback, what was it?
I think the pushback was coming from just the underlying cultural inertia that existed at USC, in that it's a surgery-first type of hospital, and we had to kind of adapt to the idiosyncrasies of each surgeon and give a little, take a little, to come to a compromise, so to speak. And before rolling out these protocols, we would have formal meetings with surgeons in each department and basically ask for their approval. And once we had their approval, it allowed us to build momentum, implement the protocol, and we've taken off since.
So of the last thing I'll ask you is the litmus test, from my experience, has been the NPO guidelines before surgery.
Okay.
So that was the hardest thing to implement in the UK initially, because everyone knows a different thing to be a fact. How did that go?
There was some resistance at first, but again, I pitched it as, NPO status and aspiration prophylaxis is kind of our wheelhouse. And if we're comfortable with our, recommended guidelines, they should be as well. And it's on us if there is an untoward event, and to date there hasn't been. Another area where there was some resistance was the preoperative oral medication loading. I guess along the same vein, they had the same concerns. And after showing them that doing so decreases narcotic consumption in an era where we're trying to spare opioids as best we can, it was a really nice sales pitch to the surgeons, and they've been bought in ever since.
Right. And so what would you say the adoption rate for your anesthesia team is for enhanced recovery pathways?
I think at first, even within our department, there is some resistance, some skepticism. But as we've, in either abstract form or qualitatively shown that what we're doing works, we now have a lot of momentum. And I'd say for the most part, the anesthesia personnel are very excited about what we're doing.
Good. Well, Robin, a couple more questions before we wrap up. You were showing me this packet that you are giving out to each one of the patients. And I know I have a ton of questions people ask about, what do we give out to patients? How do you give it out? How do you make this process work? Because, team anesthesia, we're always focused on the inter-op portion. And we just think enhanced recovery is multimodal pain management, fluid therapy, things like that. But it's so much more than that.
So I think that, an inappropriate anesthetic can kind of set the patient in the wrong direction. Yeah. And one of the things that we emphasized in our intraoperative protocol is we want these patients out of bed as soon as possible. We want them eating as soon as possible. And then we want their pain appropriately controlled. And I feel like the anesthetic comprises a very small part of the patient's length of stay, but if done incorrectly, it can really defeat the purpose of what we're doing.
One of my elevator pitches used to be that we can't make bad surgery good, but there's no doubt that we can make good surgery bad.
Absolutely. That's 100% fair.
So going beyond then anesthesia and getting everybody else on board, and it's not just us, tell us a little bit about kind of what your program looks like start to finish, and then how you communicate with your patients and bring them in. Really, as we know, enhanced recovery is all about the patient-centered care.
Correct. Basically, an analogy that I use for enhanced recovery is you would never send someone in to take an exam in school without preparing for that exam, correct? So
I've got one child who doesn't agree.
Yeah, there's always the exception to the rule. Sometimes there are the ones that still do well, and that's true. That's an exception to the rule. However, we realize that if we really prepare our patients effectively and let them know what to expect, understand what they can do themselves to improve this whole process of having surgery, and it's a very convoluted system to go through and learn this. It's very difficult for a patient who's never been through that before to understand how they can prepare. We basically provide them with some tools. So we give them an infographic sheet that gives them some information about what enhanced recovery means.
And Robin, this thing you're holding up, can people swing by your booth and pick up a copy of that?
Absolutely. We have copies of everything, and we're very happy to share because we know this is best practice.
Great stuff.
Yeah.
We also provide the patient with, so this is our version 2.0, because as most projects, we did our PDCAs and we tried out the first version, which was this, a very
long, multi-point
goals sheet for a patient.
Yeah. And are these things you're holding up on your website somewhere as well? If we give people a link, can they get in and look at them? Or
not yet. We're working on creating this. We have a SharePoint within our intranet. But we're working on sharing this with everyone.
But we can put your contact information at the end of this. So if people want to reach out and share this information.
And of course we want to publish it.
Yes.
So maybe we should wait. Yeah.
But we have these pink folders on every nursing station throughout the hospital. And we've also provided them to every surgeon's office that care for patients that are going to be doing enhanced recovery surgeries. And basically it gives them the steps, a toolkit, how to implement this whole program and how to do this for their patients. And it includes these checklists that we use for patients. So there's a pre-surgery checklist explaining to the patient what they need to do to prepare for surgery, including their nutrition, their optimizing their physical state, exercise, avoiding alcohol, avoiding smoking. And then there's also a post-operative checklist that we provide to them in advance. And we say, these are the things that you can expect to be doing when you get out of surgery. We want you to get up out of bed and move around as soon as possible. We want you to eat normal food as soon as possible. And, we're trying to limit the amount of opioid medication. So we'd like you to continue to take the medications that your physician has prescribed for you as ordered. We also created some things to help identify the enhanced recovery patients so that everyone knows what our goals are for this patient. Once our staff learns about ERAS and they see a patient with a wristband or a sign on their door, they know these patients have some specific goals that they need to meet.
As you know, opioid reduction, particularly in the US, is a big issue.
Yeah, big issue.
And we've seen on the patients that are on these pathways a 60% reduction in opioid use.
Yes.
And that goes along with, obviously, a reduced length of stay, increased patient satisfaction, and decreased or better pain scores.
So at the moment, I see it's a pink armband that says enhanced recovery on the armband.
Yes.
Do you think, just a little bit cheeky to paraphrase Professor Tony Senegor, can you get to a point whereby the majority are on enhanced recovery, so you just give some patients an armband that says you're on an unenhanced recovery program? We're slowing down your recovery. We're objectively slowing down your recovery, not like the others. Is that a bit too cheeky?
I think that they might start demanding enhanced recovery.
That's the one.
That's it.
How come they're up and about and eating and getting ready to go home, and you've got me strapped in the bed with a whole load of with my own heroin pump to play?
And I was actually at the World Society for ERAS Congress in May, and there were several speakers that talked about we need to remove the E from ERAS because this needs to be standard care for everyone.
And I think it's important to say, referring back to EPOC and ELC studies, that this approach works for emergency patients too.
Absolutely.
Yeah, you can't do everything. You can't do the pre-operative preparation, but you can do a lot of the steps, and we know it makes a difference.
Your emergency laparotomy program that appeared to be more successful, treading carefully here, had 6 major points in it. And they were, can you remind us of them? They were pretty mainstream. They were like, get on with it.
It was physiological assessment. Think about sepsis on every patient.
Get the antibiotics in early.
get the antibiotics in early from the time the surgeon decides to operate. And this is not patients who absolutely have to go to the OR now, but so bowel obstructions, you must be in the OR within 6 hours. So stopping that bouncing of the patient from day to day. Goal-directed fluid therapy.
For everyone.
ICU for everybody. And,
bingo.
And actually, we're just submitting a paper from Bath where we've shown that if you do those things, we get the results. Yeah. And guess what? If you stop doing them, which we sort of did for a while, it goes away. And if you do it again, it gets better.
Those listening internationally who don't know it, Bath is a place in England that Carol used to work at, also known as Bath.
I always struggle with that one. Well, you guys, we could sit here and talk about it forever because this is something we're very passionate about on TopMedTalk and, of course, with Monty and Carol and everything. Congratulations for all the work. Well, first of all, your awards and things that you've gotten, but congratulations to what you're doing in your facility because it is super, super hard and it's very difficult work and it's an uphill battle most days, I know. But think of the lives that you're changing and the differences that you're making. So I commend all of you on that.
We should love to have a longer conversation at some stage about exactly what Snow's role is and whether people, if that's an accelerator. Exactly.
We actually have a couple other team members that couldn't be here with us because they were at MGMA presenting. So Dr. Kim and Eugenia Chong are the co-leaders of our team. And Eugenia is a clinical nurse specialist, while Dr. Kim is an anesthesiologist, and we come together and we bring so much from each of our perspectives in what we do. So I think having this interprofessional approach is really what has helped us reach so many people within the organization.
Well, again, thank you guys so much for sitting down with us. Thanks to everyone that's been listening at home, wherever you are in the world, to everyone out there in the audience. We really appreciate it. Be sure to subscribe to TopMedTalk if you haven't already, TopMedTalk.com. You can subscribe to our newsletter. It's non-invasive at all. I promise we're not sending you spam, but it will get you signed up. It'll get daily podcasts delivered to your favorite podcatcher or on the TopMedTalk app. As well as sending out, like I was saying before, our Editor's Top Picks, some new curated lists that we have, Editor's Top Picks, the Peri-Op Coach Series. And most importantly, it gets you signed up for this beautiful Bluetooth Marshall amp speaker that you can win. And if you're here at the conference, you don't have to take this one home to you. I'll send it to you. So you don't have to pack it. So be sure to sign up.
And whose contacts are we putting in the show notes?
Yes.
We have a special email address that we welcome all the comments and feedback and inquiries. So enhanced.recovery@med.usc.edu.
That's the ticket. All right. Well, thanks for listening, guys. Be sure to tune in at 12 o'clock where we talk to Saul Aronson and Andy Shaw. Thanks so much, you guys.
Cheers.
Thank you.
Bye-bye.
TopMedTalk.
Just a quick reminder, subscribe to TopMedTalk. We're a daily source of news and conversation focused on perioperative care. We bring you all the latest talk from all the major conferences in the perioperative space. We can also be found on Twitter, Facebook, LinkedIn, Instagram, and we now have a free mailing list with special offers and additional goodies for subscribers. Go check us out at TopMedTalk.com. That's www.topmedtalk.com.